Hi, my name is Pereira Calderon and I'm going to be talking about immunotherapy in renal cell carcinoma. Definitions. Renal cell carcinoma, or RCC, is the most common kind of kidney cancer found in adults. RCC occurs when cancer cells start growing uncontrollably in the lining of the tubules of the kidney. Immunotherapy is a type of biological therapy. Biological therapy is a type of treatment that uses substances made from living organisms to treat cancer.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread.
Applications in medicine. Immunotherapy is defined as excluding cancer by activating the autoimmune response against the tumor rather than by attacking the tumor directly. Immunotherapy can induce long-lasting anti-cancer responses owing to the generation of antigen-specific immune memory, either through memory T cells or antibodies. Several crucial steps are needed to mount an initial effective immune response against tumors.
checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well.
Pros and cons. The advent of immunotherapy has brought about a paradigm shift in the treatment of advanced RCC. Properly integrating immunotherapy into the present treatment is challenging. Preclinical research has demonstrated the role of VEGF in suppressing tumor immune responses, an attractive strategy to combine with ICIs. The results are encouraging and have led to larger confirmatory phase 3 trials, which are now active, accruing patients.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you'd get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins Group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would yes, still have the same result.
Issue applied in Ecuador. Renal cell carcinoma is the third urological cancer, representing 3% of all cancers in women and 5% in men, with an incidence of around 400,000 cases worldwide. The prognosis is poor. 30% of patients are metastatic at diagnosis, and almost 30% of the remaining patients will develop metastasis detected during the follow-up. Conclusion. Renal cell carcinoma is the third type of urologic cancer and has a poor prognosis, with 30% of metastatic patients at diagnosis. The anti-angiogenics and targeted immunotherapies led to treatment remodeling, emphasizing the role of the tumor microenvironment. However, long-term responses are rare with a high rate of resistance. New strategies are emerging to improve the efficacy, and the emerging drugs are under evaluation in ongoing trials. With the different treatment options, there is an urgent need to identify biomarkers in order to predict the efficacy of drugs and to better stratify patients. Now I'm going to talk about Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definitions. Hepatitis E is a liver disease caused by the hepatitis E virus, HEV. The virus has at least 4 different types, genotypes 1, 2, and 3, and 4. Genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4 circulate in several animals, including pigs, wild boars, and deer, without causing any disease and occasionally infecting humans. The virus is shed in the stools of infected person and enters the human body through the intestine. It is transmitted mainly through contaminated drinking water.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you.
Applications in medicine. The hepatitis E virus is transmitted mainly through the fecal-oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with this disease. The risk factors for hepatitis E are related to poor sanitation, allowing virus excreted in the feces of infected people to reach drinking water supplies.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection.
Pros and cons. Pros. At the end of the therapy with Ribavirin, HEV clearance was observed in 95% of the patients. Cons. A recurrence of HEV replication occurred in 10 patients after Ribavirin was stopped. A sustained virologic response was also observed in 4 patients who had a recurrence and were retreated for a longer period. And anemia was the main identified side effect. Issue applied in Ecuador. Hepatitis is not an endemic disease in Ecuador. It is presented in less than 8% of the population. Nonetheless, there are an estimated of 20 million HEV infections worldwide every single year.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks.
Conclusion. This retrospective, multi-center study showed that Ribavirin as monotherapy may be effective in the treatment of chronic HEV infection. A 3-month course seemed to be an appropriate duration of therapy for most patients. Thank you.